And at the outset, I would like to thank the organizers for inviting me for such a wonderful meeting. I'm really honored to be here as a representative of Dr. I.C. Verma, who couldn't be here for some reason. So I hope I will be able to get his message through this talk. So my talk is on leukodystrophies with an Indian scenario. Well, when we think about leukodystrophies, we first think about what it is. So basically, they are disorders that affect the growth or maintenance of the white matter, which is the myelin. There are many definitions and there are many classifications. People tend to include many disorders into the same umbrella. So one such foundation is the United Leukodystrophy Foundation, under which there are about 40 types of disorders that are described, which may not necessarily be leukodystrophies, but they have something to do with the myelin. Classically, these are the 5-6 disorders, like adrenoleukodystrophy, metachromatic leukodystrophy, Krabbe disease, Pelizaeus-Merzbacher, Canavan, and Alexander. But in the ULF, they have also included other disorders like chromosomal, infections, vascular, and other metabolic disorders. So the term leukodystrophy was first coined by two doctors, Bilchowski and Henneberg, which, like everybody would know, it's white, and dystrophy, which is ill growth in Greek. What we tend to follow in our practice is a classification given by Powers in 2004, and there are 4 essential features for a leukodystrophy. The first being that there has to be it has to be genetically determined. So there has to be a genetic cause. Second is that it has to be a progressive, it should show a progressive clinical course. Third is that it predominantly and confluent involvement of the cerebral white matter. And the fourth, these 3 are pretty simple, but the fourth one is little, because it is the primary lesion of the myelin and myelinating cells. So not as part of a multi-system thing, but the primary lesion should be in the myelin. So that's how one can narrow down to fewer disorders. So with this definition, one would be able to exclude conditions like multiple sclerosis, infections, and nutritional, like vitamin B12 deficiency, toxic, and other causes, if we were to follow this stringent classification. So our experience at Sir Ganga Ram Hospital over the last so many years is we've had the experience of testing and diagnosing all these disorders. I have included more than the classical ones, just for the, this thing. Oh, I'm sorry. Is this the marker? Okay. So I have added cystic megalencephaly because this is the most common leukoencephalopathy that we see, although it is not one of the classical leukodystrophies. We've seen about 105 cases. And then the second one is Krabbe disease, followed by metachromatic leukodystrophies. We've also seen many cases of X-linked adrenoleukodystrophies, and the others which usually do not classify under leukodystrophies, like the GM1 and the GM2, Gaucher and Niemann-Pick. Apart from that, among the other leukodystrophies, we've seen only a few, and these I have mentioned because they have been molecularly, genetically proven. So let's start with the disorders one by one. Since MLC is the most common leukoencephalopathy that we see in our practice in India, this is the first. So this is basically, essentially it means megalencephaly is like large head. So that is present in all these children. Developmental delay in almost all, with gait problems, seizures. Seizures are present in large majority, but they are like an incidental finding. Then speech delay and neuroregression in a few patients. So the clinical features is also very varied, because the onset can be right from birth till about adulthood. And usually in our pediatric practice, we see them as young as 8 to 12 months old, when they purely come to medical attention because of the large head. Sometimes they have seizures which precipitate, and then Few of them, just to mention, Dr. Verma specifically asked me to say that these are, there are even professionals walking around who have MLC. So there's a very wide variation in the clinical phenotype in MLC. And the other neurological findings are spastic ataxia, there's some incoordination, dysarthria, but no dysmorphism. The neurophysiological studies are normal, except the EEG, which may be abnormal in these children. In the neuroimaging, I'm sure the next talk will cover this, but in particular MLC, there is a global dysmyelination right from the central semi-ovale to the subcortical U fibers. And then there is gyral widening and with cyst formation. Now these are the particular cysts that form in very classically in the temporal lobe, but also in the frontal lobe and occipital regions. There are extensive white matter changes with relative sparing of the deeper structures, like the limbs of the internal capsule and the corpus callosum. The patients with more extensive changes are usually more severely affected. So the story of MLC started with Professor Singhal, who presented an abstract in the 8th Asian Ocean Congress of Neurology in Tokyo in 1991. After that, Dr. Udani made an abstract in 1994, but it was really identified in the world outside after Dr. Wandernap's description in 1995 in a paper where she published leukoencephalopathy with swelling and discrepantly mild clinical course. So that's why this disorder is also known as Wandernap's disease. Now, genetically, the gene was first localized by Topku et al. In 2000, followed by the identification of the gene, which is now called MLC1 by Leaguewater. Now, since then, there is another gene that has been identified, which causes the same disorder, megalencephalic leukodystrophy. This was by Lopez Hernandez, very recently. So the gene MLC1 has 12 exons, and it encodes for a membrane protein, and it has 8 predicted transmembrane domains. The MLC1 is mainly located within the CNS in the astrocytes and the astrocyte junctions adjacent to the blood-brain and CSF-brain barrier. So role is, in astrocyte, this protein has a role in astrocyte osmohomeostasis. So this was described by, it is still, the pathogenesis is still largely unknown, but it is still being investigated. So the latest investigation has come up with this finding that there is a defects in the intracellular calcium dynamics, and this protein also takes part in the sodium-potassium ATPase associated molecular complex, and thus functionally it interacts with calcium-permeable channels. So essentially, if there is a mutation in the gene, the protein is defective, and this process gets haywired, and thus leads to brain swelling and fluid cysts and myelin vacuolations. So this is just a picture of the gene with the different mutations scattered all over the gene. But the interesting part for us is that there is one common gene in all the Agrawal patients. So Agrawal, as everybody knows, is a very prominent community in India, originating from North India. I'll tell you about this a little bit. There is only one publication from India, that is from All India Institute. They identified this mutation this is the most common Agrawal mutation. Apart from that, there are 2 or 3 more mutations. 2 of them were actually novel. They have not been described earlier. In our experience, which we have not published yet, but about the 105 cases, most of them were Agrawals. Most of them had homozygous Agrawal mutation. Amongst the non-Agrawals, they were varied. So this is our experience with MLC. Now, Agrawal community actually excites us because being in genetics, this has given us a very important information that this particular gene has a mutation which may have which may have started from its founder. So a little bit about the founder of Agarwal's. It occurs predominantly the disorder occurs in Agarwal community. They have origins in North India from the state of Haryana, from the legendary king Maharaja Agrasen, who lived in Agroha about 5,000 years ago. So his descendants are, of course, spread all over the world because of their astute business acumen, and but they still remain a little closed community. So we can identify with them in the genetic. So apart from MLC, we have been able to find few more founder mutations in the Agarwals. For example, in calpainopathies and hereditary fructose intolerance and so forth. So these are the genes, MLC1 being the most prominent, being responsible worldwide, being responsible for 75% of cases of MLC. Other than that, there is this hepacam gene, which actually has two patterns of inheritance. It can actually manifest either recessively or even dominantly. So after the MLC, we move on to metachromatic leukodystrophies. This is the second most common leukodystrophy in India. This was just one series that I thought I would like to share with you. It came out from Bangalore by Bindu, Mahadevan and Tally et al. They published their clinical series of 40 patients with MLD. And very interesting observation of 25 of these 40 cases were actually from consanguineous marriages. So 62.5% was the consanguinity rate. Family history was present in four cases. And they only found two types. Classically, there are three types of MLD, but in this series, they found majority, 90% of them were late infantile, whereas 10% were juvenile. The juvenile group mainly presented with behavioral problems, but there were also progressive ataxia and dysarthria. So I'll just come to the cases now, just to illustrate. This was one of our cases that the family came to us for a prenatal diagnosis in our clinic. And they brought along their previous child who had been immobilized by that time. Like he was 5 years old when he came. So upon taking the history, the child had been all right till 1 year of age, after which there was a regression in his motor milestone. So at 3.5 years of age, he had lost independent walking. And at 3 years, 9 months, he also threw a generalized tonic-clonic convulsion. After which, all his movements were totally gone. So he was completely bedridden when he came to us. So there was a rapid decline, and his speech also regressed. On examination, there was a very variable tone with peripheral hypertonia, truncal hypotonia. His head circumference was normal. So we performed an MRI. So these are the MRI findings. It showed a white matter hyperintensity in the T2 and also in the TIRIM, which were periventricular, also involving the corpus callosum, and with a very tigroid sort of appearance. There are small dots which are hypo-intense, which shows some changes in the white matter. So we suspected metachromatic leukodystrophy in this child based on the clinical and the MRI findings. And the enzyme assay was low in this case, but this was not good enough for a prenatal diagnosis. So we embarked on the gene study, and we found 2 mutations in this patient. Based on these mutations, we could then perform a prenatal diagnosis in this family. So thus far, we have done a few more cases of molecular analysis for the MLD. The ARSA gene is involved. There is only one more publication, again from All India Institute. And together, there are about 12 mutations. And other than the pseudo-deficiency allele, which was also present in 5 patients. So amongst all the mutations, only this one is a common mutation all over the world. So this is just giving you a little picture of how the mutation affects the modeling of the protein. So this particular mutation, where the tyrosine is replaced by serine, This is a normal structure of the protein where the tyrosine is hydrogen bonded with threonine at position 57 and arginine at 308. Now, subsequent to the change of this amino acid from tyrosine to serine, this particular bonding doesn't take place. And thus, the protein that is formed becomes ineffective. It's non-functional. So this is how disease comes. Now, presenting our second case, this again the couple had come for a prenatal diagnosis, and they brought along their 5-year-old boy who had a history of, who had coarse faces. These are the facial features: depressed nasal bridge, short neck, low posterior hairline, medial flaring, gum hypertrophy, and he also had ichthyosis. And there was a history of developmental delay followed by regression, and by the time he had come, he was not walking. So low. So the not only the MPS but also the aryl sulfatase A and B. So thus our diagnosis was made, and subsequent to that we even found 2 mutations in this patient to confirm the diagnosis of multiple sulfatase, which is due to mutations in this sulfate modifying gene. So this became, after this we could perform a prenatal in this family. So coming on to the case 3, this was a boy who was 8 years old, who was healthy and school going, absolutely asymptomatic, till one day when he had a brief seizure in the class. Subsequent to which he was brought to the hospital and a neuroimaging was done. Examination was normal except some mildly brisk DTRs. So this was his MRI, which showed bilaterally symmetrical white matter hyperintensity in the T2, mainly in the posterior regions, involving the genu of the corpus callosum as well as the parieto-occipital regions. So the diagnosis was fairly clear to us here, with that this was, we are dealing with an adrenoleukodystrophy. Of course, we did the confirmatory tests. The very long chain fatty acid analysis showed an elevation of the very long chain fatty acids as well as the ratios of C24 to 22, thus confirming the diagnosis of X-linked ALD. Further to that, gene sequencing also confirmed the diagnosis because there was a mutation in this patient in position 116 where the glycine was substituted by arginine. Now the same mutation was present in the mother as well. So we went on because we knew that the disease was fairly in the early stages, although not that early, but very quick HLA matching was done with family members for a bone marrow transplant, and the patient moved ahead for a bone marrow transplant. Now, subsequent to our confirmation of this diagnosis in the family, and genetic counseling, which is pretty accurate, the extended family came to light. Now, this was the maternal aunt who had a younger 6-year-old, very healthy boy. So, because of our counseling, she became concerned and she got herself tested. Once she was a carrier, we moved on to testing her little boy, who was normal, but he did have some enuresis. And to our surprise, he did have some changes starting in the splenium of the corpus callosum. Of course, he did have the mutation and his VLCFAs were all deranged. So again, this is the cousin was actually diagnosed because of the older cousin who had been affected. And in this case, we moved ahead quickly for a bone marrow because we were more sure that this would be curative for this boy. So sometimes genetic studies are very helpful. So this is the Indian scenario for the molecular testing of ABCD1, which is the gene for adrenoleukodystrophy. And there is a large series by Kumar et al. And published in PLOS 1 2011 article, where there is no common mutation. The mutations are spread all over. In our hospital, Dr. Renu Saxena has managed to study 20 cases, and we have found about 8 mutations, a novel mutation other than the known ones. Now, moving on to another, just shifting gears, this may not be a true leukodystrophy, but this is certainly has white matter disease. This was a 4-year-old girl who came to us with her parents, who were non-consanguineous, and who had motor developmental delay and muscle weakness right from birth, or say infancy. She had not achieved her head control until she was about 9 months, and she was never able to sit unsupported. She was very floppy on examination. Mentally, she was very alert and bright. And the neurological, the muscle examination showed a very low, reduced bulk, tone, and power with diminished reflexes. So we suspected congenital muscular dystrophy in this child. Her CPK was done, which was elevated, and the neuroimaging showed a leukodystrophic pattern, bilaterally diffused white matter hyperintensity. So we went ahead and performed a muscle biopsy in her with specific myrosin staining in the muscles. So this is an HNE of the patient, which shows muscular dystrophy because of the variation in fiber size and everything. This is the control spectrin stain on her muscles, and this is the myrosin, which is absolutely deficient. So subsequent to that, the parents came back for a prenatal diagnosis, and this was a control CVS. As everybody would know, the myrosin is expressed even in the placenta, so prenatal diagnosis is possible using the myrosin immunostaining in the placenta. So here we did a placenta, and this was normal staining. So subsequently, the parents had a healthy, unaffected child. So we have actually, over the last 10 or 11 years, we have performed 12 such prenatal diagnoses using immunostaining and linkage analysis, because the sequencing of the LAMA2 gene is very expensive and is not available with us. Moving on to another case or a series that we recently published, there are 3 cases of Canavan disease. One case was interesting because it actually it was an e-referral from Pakistan, and this was a 2-year-old boy born of first cousin consanguineous marriage. Boy had been floppy since 3 months of age with no head control till 6 months, had a seizure at 7 months, and at 18 to 20 months was absolutely unable to sit, stand, or even turn over in the bed. So at 2 years, he was completely bedridden, and there was no eye-to-eye contact as well. This is when the parents contacted us. So he had generalized spasticity with brisk reflexes. His head size was very huge. It was much more than the 97th percentile for age. There was a family history of similar illness in a distant relative, but that was 20 years ago, and the relative had been diagnosed to have Alexander disease because of large head and leukodystrophy. Now, another case was that of a girl who presented at 11 months, similarly with delayed motor and mental milestones, with large head, hypotonia, brisk reflexes. Third case, again, a boy who presented at 9 months with developmental delay, hypotonia, large head. He also had a seizure at 9 months. So all the MRI scans were reviewed, and this was that of a Pakistani patient, which shows typical pattern of involvement of white matter in Canavan disease, which Dr. Vanderknapp calls the centripetal progression. It starts from the subcortical fibers and moves on to the periventricular region. There is involvement of the globus pallidus here and the thalamus, with sparing of the caudate and the putamen, and largely diffuse leukodystrophy. So we were able to perform the GCMS to look for the N-acetyl aspartate, which was hugely elevated. Plasma NAA were also elevated. MRS showed a markedly elevated peak of NAA, thus confirming the diagnosis. But we went ahead and did gene sequencing for all the 3 cases, and we found 2 novel and 2 previously reported cases. So these first, family 1 and family 3, were actually consanguineous, and the other one was not. So prenatal was subsequently performed in 2 families. We are yet to perform in the Pakistani patient, but one fetus was normal and the other was affected. Now, just 2 more minutes with you, describing a new syndrome, how a discovery of new syndromes is happening nowadays in genetics. So this is a very typical case, child presenting with intellectual disability, spasticity, and ichthyosis. One would make a clinical diagnosis of Sjogren-Larsen syndrome. So this typical Sjogren-Larsen syndrome is typically caused by deficiency of the fatty aldehyde dehydrogenase enzyme, which is studied in the skin fibroblast. We did this in this child, and there was a mutation as well in the ALDH3A2 gene. But there was another case who came to us presenting absolutely similarly, with developmental delay, spasticity, and ichthyosis. Now here, this Sjogren-Larsen actually excluded by doing the enzyme assay, which came up as normal. Our researcher in USA went ahead and did the gene sequencing, but there was no mutation here. So now this case was then taken up by another researcher and embarked on exome sequencing. Now, exome sequencing is basically a newer technology which involves sequencing of the entire coding regions of the genome, which means you take all the genes and you take all the exons and the exon-intron boundaries which are coding for the proteins, and you sequence them together. Very, very big exercise. Because after the exome sequencing, they found at least 63,600 variants. They were able to filter it down, because after excluding the variants that are basically SNPs, which means they don't have any clinical significance as of now, they were able to narrow down to 7,000, and then further excluding, ultimately coming down to 3 variants. So they filtered to 3 genes. So these 3 genes were then looked further into their function, and then came to know about the ELO-VL4 gene, which had a similar sort of function in the pathogenesis. So this gene was again sequenced using the normal Sanger sequencing, and a homozygous mutation was found, and thus clinching the diagnosis. So this is a new gene which has now come up as another gene causing the same Sjogren-Larsen syndrome. So thus I conclude my talk with my acknowledgements to my mentor, Dr. I.C. Verma, and my entire team at Sir Ganga Ram Hospital. Thank you.